هتكلم عن bridging the gap in adolescent obesity. وطبعا حضراتكم بتسألوا ايه العربية اللي عمالة تروح وترجع بظهرها وترجع في مكانها تاني. المغزى من هذا الموضوع ان يعني هل نقدر نرجع في كلامنا في الأوبيسيتي والكوموربيديتيز؟ is it reversible؟ هل لو حصل type 2 diabetes resulting from obesity can it return back to normal or not؟ هو ده اللي أنا هحاول النهاردة to highlight في المحاضرة اللي أنا هقولها، وأتمنى إن على آخر المحاضرة العربية ترجع مكانها تاني وكل حاجة تبقى normal. Let me open the scene by this very impressive photo, and let me ask the audience, which is stronger, the food or our will؟ إرادتنا أقوى ولا الأكل؟ ها؟ الإرادة صعبة قوي بصراحة، خصوصا لما يبقى الأكل بالطريقة دي، صعبة قوي قوي قوي. And the other question, are we exhausting our pancreas? And the answer is a very big yes. Our pancreas is calling for help because we are eating a lot of unhealthy diet, and simply unhealthy food exhausts our pancreas because it stimulates the pancreas to produce large amounts of insulin. So it's working like a continuous machine that needs help. And as you all know, type 2 diabetes is becoming more common than before in children and adolescents. When I was a medical student, our professors used to tell us, when you see a child with diabetes, it's type 1 diabetes. But right now, we are seeing a lot of type 2 in adolescents and sometimes in children. And why? When we say why, this is why. Because obesity is being included among one of the global threats in the waiting area. We've seen the global warming, the bird flu, COVID-19, even the Russian-Ukrainian war. But obesity was described as being the top among the threats in the global area. And pediatric and adolescent obesity is a growing health problem. In 1975, there were 11 million obese child and adolescents. In 2016, it was 124 million, and it's growing more and more. And in the Newsweek, Arab children were reported to be among the 10 heaviest children in the world. And Egypt is one of the top 10 in the obesity in childhood and adolescence, as you see. So I think that obesity is becoming an exploding bomb. It could explode at any time with all its comorbidities. And childhood and adolescent obesity was described by most of the societies, including WHO, as being a disease and a health issue. It's not just being overweight and that you need to look lovely and wear nice clothes. No, it's a disease and it's a health issue which needs treatment because there are a lot of comorbidities and complications associating obesity. We all know that obesity occurs due to multifactorial things. We have genetics, endocrine, psychological, neurological, environmental, and maybe drug-induced. And please remember that the obese child is liable to be an obese adult. Not only that, all comorbidities are transferred from childhood to adulthood. And you can see here the BMI tracks into adulthood. According to the BMI being above 95th percentile, 84% will have a BMI above 30, 60% a BMI above 35, and 34 above 40 in adulthood. And this is a research predicting obesity at the age of 2 years and the weight status at the age of 35. And you can see here the severely obese child will be a severely obese adult, and the moderate and the overweight and so on. So obesity, even starting in early periods of life, could affect the adult weight. Now, this is a photo of pediatric and adolescent obesity clinic, Ain Shams University, Cairo, and I am honored to be heading this unit. It was established in June 2000, and I'm really proud to be one of the founders of this clinic. It's a once weekly clinic. We see around 30 patients per clinic. And I think if we open the number, we can see 100 patients. We have a multidisciplinary team, 2 pediatric endocrinologists, 2 to 3 pediatric endocrine trainees, psychologist, dietitian, and we have an access to geneticist and bariatric surgeon. And the sources of referral here is the local pediatricians and other Egyptian governorates. And this is the protocol that we follow at Ain Shams University when we face a case of obesity. We investigate for the cause, thyroid, calcium, rule out Cushing, genetic testing in very selected cases, and of course, very important to investigate for comorbidities, hemoglobin, lipid profile, fasting glucose, insulin, A1C, C-peptide, liver function, exclude polycystic ovary syndrome and polysomnography. And as I told you, we collaborate with genetics, hepatology, and bariatric surgery when needed. Now, let me take you to a real life case scenario from our adolescent obesity clinic at Ain Shams University. I'm going to take you step by step of what happened exactly in this girl. Now, this is a 13-year-old girl who was born normal. She started to develop weight gain, menstrual irregularities, hirsutism. She has breathing problems. Her father and maternal aunt are obese. Her paternal grandma has type 2 diabetes. She's tall, plus 2.8. The BMI SDS is high, and the waist-hip ratio is high, meaning that she has abdominal obesity. Her blood pressure is high, systolic, diastolic, and you can see the acanthosis nigricans in this girl, and she is in TANA stage 2. Now, if you look here, you can see a high blood glucose, high serum insulin, HOMA-IR, the A1C 8.1, and please be minded that this girl did not complain of any symptoms. She was accidentally discovered, and the C-peptide is normal. So the girl has silent type 2 diabetes. Her lipid profile was high, cholesterol, triglyceride, LDL, and the HDL was low, and the liver enzymes were found to be high. And as you've seen, she came only because she's obese. So the diagnosis here is exogenous obesity, type 2 diabetes, dyslipidemia, hypertension, fatty liver, depression. Again, an exploding bomb. Sad, but very common story. Nowadays, we see these complications a lot. And as you know, there are a lot of comorbidities. Children come with obesity, but there is a hidden part of the iceberg, a lot of comorbidities. And you can see, in addition to features of metabolic syndrome, there is depression, cancer, gallbladder disease, sleep apnea, osteoarthritis, stress incontinence, and disability. And this ends with a poor quality of life in those children. And instead of this, there's also the heavy economic burden of obesity, because we need a lot of money to manage all these comorbidities. And please remember that obesity predisposes to premature cardiovascular disease due to metabolic abnormalities. Of course, we all know that we have two types of obesity, the apple shape and the pear shape. Which is more dangerous, the apple or the pear? Yes, thank you very much. The apple, yeah, because it predisposes to metabolic syndrome and cardiovascular risk factors. And that's why visceral obesity is more dangerous. And abdominal obesity is the predictor of all components of metabolic syndrome, regardless the BMI, because sometimes the child is not very obese, but he or she has got abdominal obesity, and this predisposes to metabolic complications. And as you see, metabolic syndrome goes throughout the lifetime. It starts with adipogenesis, obesity, leading to type 2 diabetes, progressing from childhood through the lifetime. And as you see, there is a running vicious circle of complications predisposed by genetic and environmental factors, leading to early mortality in those children. But the question here is, who presses the start button of obesity comorbidities? And the answer is insulin resistance and inflammation, because these are the root of the process leading to cardiovascular complications, as you've seen. And visceral fat is a very important risk factor. It reduces the insulin sensitivity. And as you see in this diagram, there's a lot of contributing factors in addition to unhealthy diet, leading to metabolic syndrome, which leads to altered insulin sensitivity and type 2 diabetes. Another point is obesity-induced chronic inflammation, which is triggered by the unhealthy lifestyle. It causes a sort of inflammatory status, increasing the interleukins and the CRP, again leading to a lot of metabolic risk factors, type 2 diabetes. And this is how the food journey starts. When we eat the food, you can see here the normal insulin response. And insulin triggers the cells to remove glucose from the blood. What if there is an insulin resistance? So here the cells are ignoring the message. They do not see that the blood sugar is going up and the insulin goes high. And the final step is type 2 diabetes, when the blood sugar becomes high and then symptoms go on and so on. So simply what happens, we feel hungry, we eat a lot of carbs and sugars, the pancreas produces insulin, cells ignore the insulin, and the pancreas makes more and more insulin, and this is what we call insulin resistance, ending by type 2 diabetes. And in the presence of an unhealthy lifestyle, the vicious circle goes on and on, leading to more and more complications and comorbidities. We all know there are a lot of risk factors for type 2 diabetes, but it's important to note that there are modifiable risk factors that we can avoid. And obesity is on top of the list of modifiable risk factors for type 2 diabetes. And looking at the sequence of events of the beta cell function, you can see that the beta cell becomes stressed, and then failing beta cell leading to impaired glucose tolerance. And finally, there is apoptosis or death of the beta cell leading to type 2 diabetes. And this is how it comes in numbers. The blood sugar is normal, it starts to be impaired and then rises. And looking at the curve in blue of insulin, you can see at first insulin is high at the stage of insulin resistance, and then it goes down, leading to type 2 diabetes. And the unhealthy lifestyle causes the arrow to go in this way, on the way of type 2 diabetes. On the other hand, healthy lifestyle makes the arrow go back on the way of being normal. So type 2 diabetes is preventable and curable at some stages. Also, nutrition and lifestyle influence the course of type 2 diabetes. And this is the ISPAD Clinical Practice Guidelines 2022. They raised a very important question: to screen or not to screen for type 2 diabetes in obese child and adolescent. What do you think? Would you like to screen or not? Yes, of course. Yes, we need to screen. When to screen? At the age of 10 or more, or if the child starts puberty early, or if the BMI and the weight status is above the 85th percentile plus 2 of the following: family history, high risk race, maternal history of diabetes, insulin resistance, or associated comorbidities like dyslipidemia, PCOS, and SGA. And this was also supported by American Diabetes Association of Care 2022. Again, inflammation triggers hypertension, and visceral obesity increases the leptin, decreases adipolectin, causes inflammatory process, increased free fatty acid, and activation of renin-angiotensin system, leading to hypertension. Obesity-induced dyslipidemia is another risk factor triggered by visceral adipose tissue, which exacerbates the insulin resistance, and the vicious circle goes on. And this is to show you the atherogenic dyslipidemia. And you can see in the photo below that there is atherosclerotic plaques predisposing to coronary artery and cardiovascular complications. We used to see this in old people, but right now, because of obesity, we are seeing plaques in adolescents predisposing to cardiovascular disease. Another abnormality is obesity-induced fatty liver, triggered by insulin resistance and oxidative stress, leading to simple steatosis, fibrosis, ending unfortunately by cirrhosis. And recently it is recommended to screen for obesity comorbidities even in the absence of symptoms. Screen for diabetes, dyslipidemia, hypertension, PCOS, NASH, obstructive sleep apnea, and psychiatric problem, because early diagnosis provides early treatment and avoidance of comorbidities. Now, let's go back to the case that I showed you at the beginning, how to manage our case. We have a case of exogenous obesity, type 2 diabetes, dyslipidemia, hypertension, fatty liver, and depression. And as you see, we have a list of interconnected problems which exacerbate the vicious circle. And the cornerstones of management plan is diet, exercise, behavioral therapy, and family intervention. This is very easy. We all say this to the family, and this is what we all know. Are there any novel options nowadays for treating obesity? Yes, there are. And the speed of options is growing very, very fast in the field of adolescent obesity, especially in the last 2 years. Our aim is to shrink the fat cells. And when we look at adolescent obesity management, is it surgery? Is it healthy lifestyle? These are the two extremes. And what lies in between is pharmacotherapy of obesity, which is quite effective in weight loss. And this is the algorithm proposed in the Journal of Clinical Endocrinology and Metabolism on how to deal with obese adolescents. And as you see, you consider pharmacotherapy if you try the lifestyle changes for 6 months with no response. But the question is, do parents follow the recommendations? The answer is unfortunately no, which is quite a challenge. And sometimes we need a more effective treatment. Now, going back to the labs of this girl, as you know, she has silent type 2 diabetes. Okay, now, what is the suggested management to your mind? Please choose with me. Is it metformin and lifestyle? Who says yes for the first choice? Who would like to give metformin and lifestyle modification? Okay, thank you. What about basal insulin plus metformin plus lifestyle? Okay, who would like to treat her as DKA and start IV fluids? Of course not. She doesn't have acidosis or ketosis. Now, the answer is the first thing. Based on the ISPAD guidelines, our case fits with the first choice. If the A1C is less than 8.5 with no acidosis or ketosis, you just start metformin and healthy lifestyle. We add basal insulin to metformin if the A1C is above 8.5. You can see the girl has an A1C of 8.1. So she fits in the first category. And then you can do the antibodies to exclude type 1 and continue the sequence. What happened in this girl? She failed to lose weight after lifestyle modification for 1 year, and she is still on metformin. Is our case a candidate for anti-obesity medication? Who says yes? Why not? Yes, we can start anti-obesity medication. And these are the recommendations of pharmacotherapy in obese adolescents proposed by Endocrine Society Clinical Practice Guidelines. Failure of lifestyle modification for 6 months in adolescents above the age of 12. And this is a list of the approved anti-obesity medication. You can see here a long list, and liraglutide is approved by EMA and FDA. And please remember that metformin is not an anti-obesity medication. It's only given to children and adolescents above the age of 8 years with insulin resistance or type 2 diabetes. So we don't give it to lose weight. Can we start liraglutide in this girl? Is it approved? She's a 13-year-old girl. She didn't work on the lifestyle modification. Can we? Yes, why not? Yes, we can. So these are the indications of liraglutide in obese adolescent, above weight 60 and above the age of 12 years. We will not use the BMI by itself because in children, we use the BMI SDS or a percentile. So we cannot rely on having a BMI above 30. It's above the age of 12 and a body weight above 60. So how does it act? Liraglutide is a once daily human GLP-1 analog, which reduces the hunger and increases the satiety. And you can see here that it acts on the POMC-CART pathway. You can see it affects the hunger, it affects the satiety by modifying the arcuate nucleus, POMC-CART, neuropeptide, and agouti peptide pathway. Now, this is a research that showed that liraglutide influences all dimensions of appetite. It increases the satiety, reduces the hunger, it increases the fullness and prospective food consumption. And what we mean by prospective food consumption, thinking about the food and looking what will the child eat in the coming few minutes or hours. So this is the dose escalation in those patients. It's important to increase it gradually to improve the tolerability. And this is a research on type 2 diabetes showing significant change in the baseline A1C in those with type 2 diabetes and significant decrease in the fasting blood sugar in those with type 2 diabetes and significant decrease in the BMI Z score in type 2 children who were on liraglutide. And here it's important to note in this article published in the New England Journal of Medicine that liraglutide up to 1.8 milligrams per day is efficacious in improving glycemic control in children and adolescents with type 2 diabetes. But take care, the upper dose here is 1.8. It's not 3 milligram like in obese children. Now, FDA approved liraglutide for pediatric patients with type 2 diabetes 10 years and more with a maximum dose 1.8 milligrams per day. And this was published in Clinical Endocrinology 2022. So it's very recent. Another good news is the approval of the once weekly semaglutide in adolescents with obesity. And this is a very fresh news. It was approved this year, January 2023, for obese children above the age of 12 as well. And there are some pharmacotherapies for treating adolescent obesity like metreleptin. Sorry, ممكن بس دقيقتين كمان. The FDA approved, as you see, we have the metreleptin in those with congenital leptin deficiency and melanocortin receptor 4 agonist in those with melanocortin receptor 4 deficiency. And this is above the age of 6 years. And there is under review medication like exenatide, Byetta, which is used in Prader-Willi patients in adults. And when we say it's approved in adults, this means it's on the way for children and adolescents. Bariatric surgery is another dilemma, and it's not an easy option, by the way. You can see in the first box the indications if you have a BMI of 35 to 39 plus comorbidities, or if there is a BMI above 40, whatever, in the presence of comorbidities. Be aware that the child needs to be post-pubertal and near the final height. Obesity despite compliance, and of course, we need an expert bariatric surgeon. Not anyone can do this. This is important. And of course, the response to treatment variety is heterogeneous. Now, remember the girl had hirsutism and she had menstrual irregularities. Would you like to investigate, or is it okay? She's obese, no problem. Yeah, of course. What are the suggested investigations here? Thank you. Yes, I can hear FSH, LH. The ratio was borderline, the estradiol is normal. We found a high total and free testosterone, and the adrenal androgens were normal. So she doesn't have CAH, she just has increased androgens. And look at the pelvic abdominal ultrasound, bilaterally enlarged ovaries, 8 ml, with a normal echogenicity of stroma, 5 follicles, 1 millimeter in diameter. Does she fit with polycystic ovary criteria by ultrasound? Yes or no? Okay, let's see. These are the international consensus definition for criteria of having polycystic ovary. More than 12 follicles, at least 2 to 9 millimeters in diameter. You can see here, it's 5 follicles, 1 millimeter. Okay, increased volume more than 10 ml. Look here, 8 ml. So she does not fit with criteria of polycystic ovary by ultrasound. Sometimes there is increased string of pearls, echogenic stroma, thick capsule, and bilateral. Be aware that polycystic ovary syndrome, only in 20 to 30%, you can see the criteria. So the ultrasonographic findings by itself does not equate the diagnosis of polycystic ovary, simply because you can see updated criteria for diagnosis of polycystic ovary. It's only one of the criteria, having polycystic ovaries on ultrasound. And which type of polycystic ovary? Our case fits with the second type, and this is what we call acystic polycystic ovary syndrome. Some girls with the diagnosis of polycystic ovary do not have cyst by ultrasound. Unfortunately, most of radiologists diagnose PCOS if they find 1 or 2 cysts. Of course, this is not valid. We have to see 12 cysts, 2 to 9 millimeters in diameter. Now, polycystic ovary is a vicious circle interaction between genes and environment leading to insulin resistance, hyperandrogenism, hirsutism, and triggered by adipose tissue. And you can see here that hyperinsulinemia as well is the triggering factor leading to hyperandrogenism, ovarian dysfunction, and ending by cardiovascular risk factors as well. And there is a clear association between polycystic ovary and BMI. And if you look here, you can see, of course, not every girl with polycystic ovary is obese, but most of them are obese. And you can see here the two bars in blue. Class 2 and class 3 obesity are the highest to have polycystic ovary. And there are some possible long-term risks like subfertility, obstetric complications, cardiovascular risk, psychological, malignancy, metabolic syndrome, and weight reduction improves the long-term risk in women and girls with polycystic ovary. And you can see here all the parameters are improved. So it also improves the hormonal parameters in girls and women with polycystic ovary, like reduction ovarian volume, the number of follicles, the birth, the improvement of spontaneous ovulation, pregnancy, regularity of the cycles, and so on. In addition, there is a favorable impact on weight loss of the offspring. It even affects the affection of the offspring that this girl or woman is going to give birth to by reducing the prevalence of obesity in the offspring, insulin sensitivity, lipid profile, and C-reactive protein. Now, the important part in the managing of PCOS is the lifestyle. Please remember that lifestyle modification is the cornerstone in those girls. It affects the metabolic dysfunction, the hyperandrogenism, and fertility. Now, my question here, could liraglutide be useful in girls with polycystic ovary? Yes or no? Yes, of course, it applies. Now, recent research published in 2020 showed that GLP-1 agonist, liraglutide, reduces the obesity, the androgen excess, and the reproductive function. And this is a recent research showing that it improves the bleeding ratio, free testosterone, ovarian volume, and the weight. And liraglutide 1.8 is effective, but be aware it's not yet approved for treating polycystic ovary syndrome. I use it in those girls, but it is not yet approved. As you see here, it improves menstrual cycle frequency, hyperandrogenism, and glycemic parameters. Not only that, our colleagues use it to reduce the weight and to give a very low dose in addition to metformin in the preconception phase of IVF to improve the weight and fertility. So finally, I think that we need to redirect the arrow this way. And of course, prevention and early treatment of obesity and its comorbidities is really crucial. It's good to have something that is preventable, that we can stop. So obesity and type 2 diabetes are preventable, and we need to work on that. And these are nice quotes that I've seen. Food is the most abused and anxiety drugs. Whenever we are happy, we eat. Whenever we are sad, we eat. We eat all the time. So we need to work on this. And exercise is the most underutilized antidepressant. It really improves the mood. So we need to go for exercise rather than food. And Hippocrates once said, leave your drugs in the chemist pot if you can cure your patient with food. So sometimes it's food that will have a cure. And let your food be your medicine, and your medicine will be your food. Remember 5210, 5 fruits and veggies, 2 hours or less screen time, 1 hour or more activity, 0 sugary drink. And remember, obesity is a chronic disease. It's not a luxurious thing. My final thoughts are, childhood and adolescent obesity is a growing global health problem. Arab children are among the heaviest in the world, and Egypt is among the top 10. The prevalence of type 2 diabetes in children and adolescents is much higher. Inflammation is the root of most comorbidities. The horizon of anti-obesity medications, including liraglutide in adolescents, is expanding. And always remember, obesity is only the tip of the iceberg. Below the tip lies a very long list of comorbidities that we need to dig for whenever we see an obese child and adolescent. I think you agree with me that fighting childhood and adolescent obesity is a real challenge, and the wave is getting higher and higher. We need to put our hands together to fight this pandemic. Again, let me end by this very impressive photo again and ask the audience, which is stronger, the food or our will? Thank you very much for your attention.
ثانك يو فيري ماتش دكتوره رشا، المحاضره رائعه
ميرسي يا دكتوره.
بس انا نفسي اسال على حاجه
اتفضلي حضرتك.
لاحظتها في كل الناس المعامل، الهوما والهوما اي ار انا
أيوة.
شايفه في
not accurate at all.
طبعا ملاش
هي
انا اعمل
حاجه يعني موضه طالعه زي ايام الفيتامين
يعني
دي.
انا مبسوطه ان حضرتك في المين انفستيجيشن بتاع الاوبيزيتي ما ذكرتهاش.
ايوه مش مهمه خالص.
ده لازم ناكد على بتوع العلاج الطبيعي اللي بيعالجوا الناس الاوفر ويت
وزملائنا في النيوتريشن برضه لانهم ساعات بيعالجوا
أيوة.
على اساسها
بيطلبوها نون ستوب، فلوس على الفاضي.
لا ومش accurate، ما اقدرش اعالج على اساسها.
يعني انا فعلا عاوزه حضرتك اشرتي اليها ان انا اكد مفيش داعي للهوما الا لو كنت بعمل ريسيرش. otherwise I don't need it.
هو احنا الحقيقه ممكن نعتمد يا اما على الكلينيكال اللي هو الاكانثوزس طبعا دي بتتحدث عن نفسها، او الفاستنج جلوكوز انسولين ريشيو.
لا والتراكمي كمان مفيد.
التراكمي لو وصل بالظبط، وممكن فاستنج جلوكوز انسولين ريشيو برضو very sensitive. Thank you يا دكتوره منى. يعملوا الهوما. صحيح. لا ده هم على فكره بيعملوها لوحدها كده من غير فاستنج جلوكوز ولا انسولين ولا A1C، هي الهوما بس كده تمام كده.
Thank you Professor Rasha for the outstanding lecture.
Thank you.
مفصلة، اتعلمنا استفدنا كتير منها. بس طبعا انت عندك الفيلد بتاع الفارماكوثيرابي في التشايلد هود اند ادوليسنت اوبيزيتي، بالذات الريشيال فاكتورز اللي عندنا احنا ك جينيتك inheritance يعني للدايابيتس تايب 2 وللميتابوليك سيندروم. فبس انا I wonder why you didn't mention الرول بتاع الكونتراسبتيف pills to put the ovaries at rest في حالات الهايبر اندروجينيميا الناتجه مع او يعني المصحوبه مع الهايبر انسولين.
لا ده طبعا رول معروف، ده البيسك تريتمنت يعني ده موجود. انا الحقيقه كنت فوكسنج اكتر على حته الليراجلوتايد، انما طبعا احنا بنعالج الانسولين ريزيستنس بميتفورمين. اللي عندهم menstrual irregularities اكيد هندي اورال كونتراسبتيف بيلز، احيانا بندي انتي اندروجين لو الهرشيتيزم سيفير، والليراجلوتايد ده بس نوفل حاجه اضافيه بالاضافه للكلاسيكال تريتمنت اللي بتقوليه يا دكتوره منى.
اكيد. شكرا.
ميرسي.